incursion en Allemagne avec le professeur Michael Siniatchkin, hein, qui est professeur donc, de neuropédiatrie et également qui est directeur à la clinique de psychothérapie et psychiatrie de l'enfant et de l'adolescent et qui coordonne également le projet européen STIPED. Voilà, en Zoom.
Hello. Hi.
Hi.
Are you hearing me well? And do you see my presentation? Can you possibly just... Oh, great. Very nice. Okay. Okay. My dear colleagues, dear friends, thank you very much for the invitation to give a talk on the topic transcranial direct current stimulation in ADHD. I very apologize that I was not able to make a presentation in present because of Corona. I have to keep quarantine till the end of the next week. So I allowed to make a presentation just online. I will talk about the significance of transcranial direct current stimulation to treat patients with ADHD. And after a short introduction, I can explain you what it is, TDCS, transcranial direct current stimulation. I'll show how TDCS can be applied in children and adolescents. I will demonstrate you that there are some specific aspects we have to consider applying TDCS in children, and have a relatively safe method which provides a perspective to use this in clinical routine. And after that, I go to the overview how TDCS have been already proven in different studies, randomized controlled clinical studies, and in different one-side experiments to show the potential how TDCS can be used in the future to treat ADHD, and then show and say a few words about our STIPED project. STIPED means stimulation in pediatrics. Firstly, TDCS, transcranial direct current stimulation. It's a relatively old method. The first experiences to use TDCS was in ancient Greek and in Egypt, where different electric fishes have been used, for example, to treat migraine pain. The first publication about the application of TDCS in human have been done at the beginning of 19th century. Giuseppe Aldini, it was a cousin of Alessandro Volta, used electrical stimulation to treat, very, very interesting, to treat depression in adults using a relatively advantageous density of stimulation from about 20 to 30 milliamp. After this study, it's interesting that we have a relatively large gap between beginning of 20th century and the end of 20th century. So very few studies have been done, especially in Russia, in Institute of Brain, where so-called micropolarization have been applied to treat different neuropsychiatric disorders. The renaissance of TDCS we experienced at the beginning of 2000s, just at the beginning of millennium. Michael Nietzsche and David Libertans are depicted on the picture C. They performed the first experiments using TDCS firstly to stimulate motor cortex in healthy adults. You see that TDCS is a very, very simple method. You have the stimulator, and you have, in the first experiments, have been used only two different electrodes. The electrical currents is going from the anode to the cathode and stimulate the brain area just underlying the electrodes and the area between these electrodes, depending on the so-called montage. So how you place a anode and cathode on the head, you have a possibility to influence different brain areas. How you influence this? This is very, very good shown on the picture B. TDCS is a method which influences the readiness, the anticipation of the neural tissue to react to different stimuli. The influences the readiness potential, as in like resting potential of the neural cell to respond, for example, on excitatory or inhibitory stimuli. And it's very, very shown in the picture B, where you see that the cathodial TDCS reduces cortical excitability, where it is very, very good seen on the upper part where the neurons stop to firing. And on the right part, you see that the anodal stimulation increases excitability, increases the readiness of the nervous cells to respond. And in human, it have been investigated firstly using transcranial magnetic stimulation. So the anodal stimulation increase the amplitude of motor evoked potentials, demonstrating an increase of excitability, and total stimulation reduce the amplitude of motor evoked potentials, demonstrating the reduction of the excitability or inhibition in the cortex. So you can imagine that TDCS is a simple method to have an influence on cortical excitability and to influence in such a way to influence the brain function, which is related to the stimulated or inhibited brain area. The method is really cheap at the moment, so you can just see different videos in YouTube where we have good guidelines how you can buy different parts for stimulator and for electrodes in a supermarket and construct a stimulator for possibly 20 euro and apply the stimulator already to influence neuropsychological function. It's a non-invasive method. It's very, very easy to perform and produces relatively few side effects. It has been shown in different studies, safe and well tolerable method. It influences neuropsychological function. I will show you that there is a huge number of different studies. Depending on the area of stimulation, depending on the montage, you have a relatively clear and significant possibility to enhance or reduce different neuropsychological functions. The TDCS have after effects, which is the promising aspect for our patients, because we apply TDCS only possibly for 1 hour, but have then after effects which can last for sometimes hours and sometimes days. For example, we know that from studies which have been done in depression, then application of TDCS over 2 weeks can produce after effects which can last for 2 or 3 months. And it is very, very promising for therapy because we don't have to stimulate the whole time, but only for a very, very limited time, and then expect that our effects will endure for a longer time. The TCS may be applied over one region, but it's very, very interesting that if we just influence on only one target in the brain, we have a possibility to influence the whole network, which is also a very promising aspect because we can affect in such a way very complex neurophysiological functions. And this method is suitable for randomized double-blind sham control clinical studies, because if you apply sham stimulation, it's really is a real sham. So the patients are unable or have a very huge difficulties to differentiate between real stimulation and the sham stimulation. In such a way, you can really do a realistic blinding by application of such a method, which is, for example, very, very difficult to do using the transcranial magnetic stimulation. So in the last time, you see, TDCS have been applied in different studies, and the number of studies is really increasing. We have also an increasing number of randomized control clinical studies where we have more experience in application of TDCS to treat different conditions. And one example how TDCS influencing brain and how TDCS may be used also for treat ADHD is, for example, one study is one of the thousands which just demonstrates the logic of TDCS. In this study, they have done working memory task using the classical and-back paradigm. You see here on the left upper part, we presented patients different pictures, and the patients have to press a button as soon as possible if the current picture corresponds with the picture coming before. So the patients have to monitor the whole time. This picture was before, this picture was before. If they have a fit, if they have a good correspondence, they have to press a button. It's the task which is related to continuous monitoring, to continuous attention, and also is related to different kind of errors. We can very good calculate so-called accuracy. This is sum of errors of omission and commission errors which demonstrate how good the patients have managed the task. In these patients, we performed two kinds of TDCS. We used the classical montage using only 2 electrodes. One electrode was placed over the left dorsolateral prefrontal cortex, and you know that the left DLPFC is the main structure which have an influence on the working memory, and the cathodic electrode was set on the right orbitofrontal cortex. So we stimulated anodally the left prefrontal cortex and cathodally the right prefrontal cortex. By using these 2 electrodes, you see how distributed and diffuse is the distribution of the electrical current. So the stimulation is not focused enough if you use only 2 electrodes, and you influence very huge areas of the brain between these electrodes. The other kind of stimulation is to use so-called high density stimulation, where you apply different electrodes. Like here in this case, here anodal electrodes over the left DLPFC, the 3 anodal electrodes were set over the focused of the target area, and the cathodal electrodes were placed just on the right orbitofrontal cortex and behind our anodal electrodes. In such a way, you have a possibility to stimulate much more focally, to address only one brain function which you'd like to stimulate. So we'll look on the accuracy in these patients, and you can really recognize that the sham stimulation didn't influence accuracy, but we have a good effects on the accuracy using the so-called bipolar stimulation, only using 2 electrodes, and multipolar or high density stimulation using more electrodes. But high density stimulation was much more effective than the bipolar stimulation. Interesting is, and I think that's one of the most desirable aspects by using stimulation in people, these clear differences between sham, anodal, and anodal stimulation were only for so-called low performer, only for people which performed in the working memory task worse than so-called high performer. The stimulation can work only in people which have a really affected functionality, which have difficulties to respond, which have difficulties to produce any task, to react on any task. So the TDCS have a potential to influence neurophysiological function in such people which are really characterized by some kinds of deficits. And it is also a good knowledge and also good information we can use, because the more affected are people, for example, with ADHD or with other difficulties, other neuropsychological functions, the better is our TDCS effects and the more chances we have to apply this method in the clinical routine. How it is application in TDCS in children. Here you see results of a 1 milliamp TDCS, which we have applied in children and controlled for TDCS effects using transcranial magnetic stimulation. You see amplitudes of so-called motor evoked potentials, and it was very surprisingly to see that the 1 milliamp TDCS produces both increase of excitability and by using of anodal and of cathodal stimulation. It was a paradoxical effect. If we expect to expect a reduction of cortical excitability by using the cathodal stimulation, the children react paradoxically with an increase of excitability on the cathodal stimulation. And it was related to the stimulation intensity, because if we use a 0.5 milliamp TDCS, a lower intensity of stimulation, our cathodal stimulation becomes to be really inhibitory. So the stimulation intensity have to be adjusted to the age of the children, to the anatomical aspects of the brain, in order to be really effective. And this is possibly related to different anatomical characteristics. For example, here you see negative correlations between thickness of the skull and current density. The lower is the thickness, the more is the current density. And in children, we have lower thicknesses. So especially in children, you see a much more distributed TDCS effects, much more distributed current density, and also larger density effects. So the effect of TCS in children seems to be much more pronounced than, for example, in adolescents or in adults. And this is a possible explanation for paradoxical effects. If you look on this picture, you can possibly expect that children would produce more side effects than adults, but it's not the case. And the side effects are relatively mild, pronounced. And for example, in our TCS study in STIPET, they have very, very few children which disrupted TCS sessions and don't continued their participation in the study. Here's an overview about different side effects. On the children experienced tingling and itching, burning sensation and pain, but surprisingly, the children which used sham stimulation produced very, very similar side effects than, for example, children which were stimulated with anodal or with cathodal stimulation. So the method is very, very tolerated, and the side effects are relatively mild, and the method can be applied in children with as a relatively safe method. In which disorders the GCS have a potential to be applied. And here is a small overview about studies which have been done in adults. They have a good experiences by application of GCS in patients with depression, patients with auditory and verbal hallucinations, aphasia, chronic pain, tobacco smoking, epilepsy and migraine, patients with eating disorders and cognitive disorders like in Alzheimer's disease or mild cognitive impairment. In children, we have also some number of studies which demonstrate an effect in ADHD, hemiplegia, tic and Tourette syndrome, dyslexia, autism. We have good evidence from a number of studies how GCS influences social cognition. We have evidences for epilepsy, trauma, and also ethical aspects will be discussed very intensively in the context of application of TDCS in children and adolescents. Today, I will only concentrate on studies which have been done in patients with ADHD. You are all specialists, and I don't go very deeply in the description of the symptoms. ADHD is related to a symptom complex of inattention, hyperactivity, impulsivity, and is also associated with different neuropsychological deficits. Deficits can be illustrated in this picture, for example, by using classical tasks of attention or impulsivity, like go-no-go task. The patients produce very, very huge variance of reaction times. You can see here in the green points represent reaction time, these patients by go-no-go task, and the red points show different errors, and you recognize that the patients are characterized by a huge number of different errors and by increased response variability, by increased distribution of responses. If patients have a methylphenidate, so the reaction time is going down, the variability is going down, and also the number of errors is also going down. So in different studies have been demonstrated, especially response variability and accuracy in different continuous performance tasks and tasks on attention, good biomarkers and good characteristics of ADHD. Which structure is responsible for that? And meta-analysis demonstrated especially two structures can be described as a driving at the target structures which substantially influence these neuropsychological functions. Firstly is the dorsolateral prefrontal cortex, especially the left dorsolateral prefrontal cortex, which is mostly related to executive functions and to working memory function, and the most tasks of impulsivity are attributed to activity in the right inferior frontal cortex. So these two structures can be found as a possible target for GCS in order to influence clinical symptoms of these patients. Indirect and a very indirect indication for that is our study where we performed ADHD summer camps like a neuropsychological training in a group of patients with ADHD, and you can see that patients have underactivation in the prefrontal cortex, in basal ganglia and SMA before the training, and after the training there is substantial activity seen in the prefrontal cortex, parietal cortex, and the clinical symptoms and response variability correlated with an increase in this area. The more was the activation in this area, the less was the response variability, and the less were the number of symptoms and expression of ADHD in this patient. So it can be suggested that the influence of this function would possibly influence also symptoms of ADHD. And it was the case in study done by Sotnikova. She investigated 16 adolescents using NBAC task. And if you look firstly on the results in the behavior, so you can expect that the responses, reaction time will increase with the increasing difficulty of the task. It was the same in the sham stimulation, showing, for example, by blue bars, but in TDCS, this effect was less pronounced. So TDCS was able to reduce responses, especially for very, very complex tasks, and was true for reaction time and also for reaction time variability. And this was associated with increases in hemodynamic response. The stimulation have been performed inside MR scanner, and Sotnikov et al. Observed the increase of activation in one back and two back task under the stimulating electrode in the left dorsolateral prefrontal cortex, but also in the whole network of activity which was related to the motor function and also to the working memory task. So the activation was seen in the parietal cortex, in premotor cortex, sensory motor cortex, and so on, and in supplementary motor areas. Interesting was that the more was activation in the left DLPFC, left SMA, and left premotor cortex in these patients under TDCS, the less were the symptoms of ADHD, the less were the reaction time and reaction time variability in these patients. The question is, how sustainable are these effects? Can we expect that these effects will possibly endure the longer time, and we can hope that the changes which we have produced using TDCS will last through the longer time and also have an influence on the behavior? And after performing TDCS in the scanner, we performed a resting state fMRI and looked on the connectivity. And we were very, very surprised analyzing the connectivity and rest after the end of the task. We looked for resting state functional connectivity, firstly just analyzing the whole brain, and we're very, very surprised to see that especially the connectivity increased after TDCS in the area we have stimulated. So in our left dorsolateral prefrontal cortex. If we put the seed, the area of interest in this connectivity pattern, in this blob of connectivity, and look which other brain areas will be active and we are connected with this area. So we were very surprised to see that the other areas of working memory were activated, were very, very closely connected to our area in left dorsolateral prefrontal cortex. So it seems likely that the network of connectivity survives the end of stimulation and is still active and still present, and is demonstrating like a basis for effective information processing after the end of stimulation. Can be also shown and demonstrated by statistics. You see here which network is active by TDCS, and it's very clear that the connectivity in working memory network and a network of executive control is still, the connectivity is still present after the end of stimulation and not in different other networks. These sustainable effects were also related to clinical effects. The stimulation have been done over 5 consecutive days, and you can see here that 5 days of stimulation produced a reduction of attention, inattention. Attention was better after the stimulation on the 5th day, and this effect was also sustainable 7 days after the end of stimulation, and was correlated also with a substantial and significant improvement in impulsivity. It seems likely that the clinical symptoms improve, and this improvement is also long-lasting and also sustainable through time. These effects have been supported by different other studies, like, for example, from the who investigated 15 patients with ADHD and proved different montages and demonstrated an 1 milliamp TDCS over left dorsolateral prefrontal cortex with the cathode of the right orbitofrontal cortex produces significant improvement in working memory, impulse control, and in executive functions. This is another study which focused on the stimulation not of DLPFC, but of the right inferior frontal cortex, stimulating this area with 1 milliamp anode, and the cathode was on the left mastoid. This study demonstrated you can see here on commission errors and on reaction time variability, then in patients with ADHD, there was a significant reduction in commission errors, which was not demonstrated in the control group and was also not seen in by using the cathodic stimulation. And the same was true also for reaction time variability. It seems likely that by using of the typical classical task of impulsivity, like a flanker task, the impulsivity can be reduced using TDCS over the right inferior frontal gyrus. Another study have proven significance of TDCS by stimulating of the right posterior parietal cortex. You know that the posterior attention bundle, posterior parietal cortex have a very significant role in controlling attention. And in this study, 19 children have been studied in the randomized sham-controlled crossover design. And what you can see here, that especially the attention orienting have been influenced by using TDCS over the parietal cortex, but interesting is that the executive control was worsened by using TDCS. So by application of the specific stimulation of the area, we can influence a specific function and can even negatively influence, worsen another function we are not interested for, and where possibly we have an indirect effect on the neuropsychological function. And this is one of the last studies, possibly the largest one, which performed stimulation in 50 children with ADHD by using 15 sessions with a 1 milliamp anodal stimulation of the right inferior frontal gyrus. There was a randomized sham-controlled design, and interesting is to see that there was no effect of anodal stimulation on clinical symptoms. Even if you look, for example, here on the clinical efficacy, so the clinical efficacy here is in the upper part. On the upper part, you see the effects of TDCS, and on the lower part, the baseline data in both groups, which received anodal stimulation or the group which received the sham stimulation. There was a significant and clear reduction of clinical symptoms, reduction of inattention, hyperactivity, and impulsivity, but there was no difference between the groups concerning the effect. So it seems likely that TDCS in such a large group of patients have no effect on clinical symptoms. These patients, it may be explained possibly by the area of stimulation. Possibly is the inferior frontal gyrus not an appropriate target for stimulation. Possibly explanation is that only in this study, patients have a medication, and the most of patients, almost all of this, have a very good experience with methylphenidate. And if the patients go into the stimulation protocol and have already an effective medication, so you cannot expect a substantial improvement in clinical symptoms. Possibly it is an explanation. Possibly the montage or the protocol can explain this. We have really different parameters we have to control in order to find explanation which protocol will be effective and which not. This is a small summary which demonstrates you that the most studies which have been performed in children and adolescents with ADHD have done stimulation with 1 milliampere. The stimulation was done mostly over the left dorsolateral prefrontal cortex. Some studies used the target the right inferior frontal gyrus. Only one study, the parietal cortex. The most studies, except of one, demonstrated a clear and significant effects on inhibition, interference control, attention, working memory network, on risky decision making, and also on clinical symptoms. The most studies demonstrated that stimulation over 5 days or possibly more days are more effective, and we have to stimulate over a longer time in order to get clinical effects. Only one, the last study, was critical and demonstrated no cognitive effects, and we need more data in order to be sure how the method is effective. So I demonstrated you in children and adolescents, DCS can be effectively used to influence neuronal activity and brain function. The effects of DCS can be proven in the left dorsolateral prefrontal cortex. There is some potential to use other target areas. There is only 5 consecutive days. DCS can reduce symptoms of ADHD, but over the 15 consecutive days, we see that at least applied over the right inferior frontal gyrus, DCS seems to be not effective. Effects of DCS in ADHD are associated with changes in motor and executive function dependent on symptom load. The more are the symptoms, the more severe is the ADHD, the more is the effect of stimulation. Patients have been demonstrated in different studies already, and DCS is a safe and well-tolerated method as demonstrated in healthy and in affected children. What we can learn from the DCS story, we have a long way on the top, and we have to solve different problems. For example, which area is especially interesting for us, and especially in which particular patients, which area have to be implied in order to be effective using the stimulation. How we have to place electrode in order to get this area. What's the effect of brain development of parameters of stimulation? Do we have to adjust our stimulation intensity to the different developmental aspects in order to be effective? Can be used individual protocol, because the anatomy of the brain, especially the pre-activation and functional characteristics of the brain, are very, very individual, and they may influence effective stimulation as well. How are the mechanisms, and how can we predict the efficacy of stimulation based on different biomarkers, and of course, the safety aspects of stimulation and acceptance of this method in the community have to be addressed in the future. The most of these aspects we address in our consortium, STIPET consortium, Stimulation in Pediatrics. We perform five randomized controlled clinical trials. 4 trials in patients with ADHD, and 1 trial in patients with autism. University of Tours is also participating in this trial, especially in the aspects of autism, and I'm very, very thankful that you have, Frederick, recruited a very good number of patients and helped a lot in our trial. The trials in autism and in ADHD are closed now, and we are preparing data for the first analysis, and I think that the first analysis will be available at least possibly in May or possibly in June, and we can then really evaluate how effective was this method in children and adolescents. One of special aspects of TDCS in our STIPET consortium is to apply TDCS at home. We developed a special device, home test device, for home application in children and adolescents in collaboration with our partners in Barcelona. We try to integrate this device in telemedical health service and produce like a remote control over stimulation and symptoms in order to be safe by application of this method. Of course, we considered different ethical guidelines and used questionnaires and interviews in order to look how the methods can be implemented in the clinical practice and then in the community. And the stimulation have been performed using an individual pipeline. We calculated individual electrode placements and individual distribution of electrical currents in the brain in order to address regions of interest in the best way in order to be effective by using stimulation. And of course, we looked on different aspects like age and anatomical specialities of the brain and anatomical features and different biomarkers which possibly may explain effects of stimulation. Now, all these results will be available so about at the end of the spring and possibly in the summer, and we'll enjoy results in the next time. We'll share them also with the community and with all of you. And this moment, I'd like to thank you for your attention and very, very happy to answer all your questions. Thank you very much.
Thank you very much, Professor, for your very interesting speech. Now, any question in the audience?
On n'a pas de questions non plus sur le chat. Je ne sais pas si Claire non, okay. No, just Michael, I just wanted to thank you. We are really sorry for you to not be here with us today. Je ne sais pas si je peux voir Michael ou pas, c'est plutôt que moi. Oui, c'est trop blanc dans le. Voilà. Thank you. Yes. Thank you very much. I know that we haven't yet the data from the ASD children that have been included in STIPED, but could you please remind us for in the protocol, you know, we have at the task with the fMRI results based on the anatomical analysis before and after TDCS stimulation to try to better focus on the structural aspect of the brain to be sure that we have an individualized stimulation in TDCS. You have not mentioned this in the data, but can you please just give a few words about this, about the baseline with the fMRI or MRI data analysis before TDCS?
Thank you. There are different aspects we have to consider using TDCS for individual aspects. First of all, it's an anatomical features of the brain, like the thickness of the skull. For example, these have substantial influence, and we have forcibly looked on different patients which have large sickness, like for example, adolescents, where there is a some layer of the fat just under the skin. So this already have an influence on TDCS effects because the intensity of electrical currents is substantially reduced, and you have to adjust electrical currents, for example, for the larger thickness of the skull and also of the fat layer. In small children, the thickness is much more smaller, and that's why the stimulation intensity have to be reduced. And if you not reduce, you can produce a completely opposite effect. And this opposite effect is related to the interaction between the activity of the brain, the pre-activation level of the brain, and effects of TDCS. If you have larger activity before you start to stimulate, for example, because of stress or because of some increased cortical excitability following some kind of neurological or developmental disorders and so on. So you can also produce some paradoxical effects. Large intensity of stimulation and an increased level of pre-activation may influence the responsibility and influence also the outcome, individual outcome. So the fMRI can be used to characterize the level of preactivation in a particular structure, and using this and knowing the level of preactivation, you can adjust stimulation intensity. Another aspect is, if we speak about the individual anatomy, is the orientation of electrical current depending on the sulci and on surface of the brain. If activity of the brain like to influence is in the sulci, is not oriented tangentially, but is deep inside the brain. So you need a special montage in order to get this area, in order to transfer the electrical current to this area. For example, very, very difficult is to address areas which are not on the surface of the brains, like the medial frontal cortex. We do now a study on a stimulation application of TDCS for influencing emotion in patients with aggressivity and aggression, and with problems with emotion regulation, and it's difficult to find a specific montage, and also to individualize this montage in order to get deeper structures which are not on the surface. And for that, you need a special modeling of electrical current with a special individual orientation of different electrodes, stimulating electrodes around a targeted area in order to be effective by applying electrical current and also by influencing neuropsychological function.
Okay, thank you very much.